سيدنا محمد وعلى آله وصحبه أجمعين. Dear professor, okay, dear guest, and dear surgeon, thank you for being with us here in our event. I'm a medical oncologist, but I'm talking on the behalf of King Abdulaziz University. It's an honor to have all of you here to discuss this serious issue where we have a lot of cases of the patients with colorectal cancer. We're going to be talking mainly about the surgical updates, and we have the honor of having Professor Gerard from Radiation Oncology, who's going to be helping us with that, and also some medical oncologists also around. We will start by a small speech by Professor Mahmoud Shaheen, the head of the colorectal cancer chair and the sponsor of this event.
Thank you very much, Shadi. Actually, I'm a guest here tonight. I'm not the dean. I'm not the chair or whatever. I'm just only a guest here. I'd like to, on behalf of the colorectal cancer chair, I'd like to thank you again for coming. Our guest from outside the Kingdom of Saudi Arabia and from inside the Kingdom of Saudi Arabia, you are more than welcome to see our colleagues where we didn't see them for quite some time. I hope that the workshop for tonight is going to be discussing some of the key issues important for our staff from the surgical department in the university and outside. Hopefully we will have some new advances from the robotic surgery point of view. Then some of the issues about screening for colorectal cancer in relation to the Kingdom of Saudi Arabia and the population of Saudi Arabia. Especially, it occurs commoner in younger age group compared to the Western communities, and it is considered one of the most common malignancy in males and the third most common malignancy in females. With this start, I would like to leave the microphone to my colleague Abdurrahman Sibyani, who's a member of the colorectal cancer chair, who's a well-known surgeon and an excellent, what I want to say, surgeon, as well as from the colonoscopy, RCPs. He's the most skillful and he has the highest number of procedures in our hospital. I'm telling you that from statistics over the last 15-20 years. So I'd like to ask Dr. Abdurrahman Sibyani to come and just maybe you give an introduction and then you moderate the whole session. Thank you very much.
Good evening, everyone. Our distinguished speakers, my colleague from Mecca, Jeddah. I hope that I am at the level of what Prof. Shaheen said, but I am not that person. I think this subject is burning in our community because colorectal cancer is first cancers in male in Saudi Arabia, second in female, and it runs aggressive course, and it affects a relatively younger age group than Western countries. I apologize for the poor attendance. Actually, we invited around 50 persons, but because there is an accident in the street, under the street, I think they are trapped there. I think we'll start by updates in robotic colorectal surgery by Dr. Francis, Professor Francis. Welcome.
Thank you very much. Firstly, for the invitation to come to this beautiful country and city. So my friends asking me, why you suddenly go to Jeddah? I said, well, I'm doing my Hajj also. So thank you very much for this beautiful place. Now, I think tonight I would like to actually just, because I see that we're going to talk about robotic first, but I think I'm just going to say a little bit about screening first, as it's on the program as well, and then we go on straight to talk about innovations in laparoscopic and something about robotic surgery. I know that you know, a lot of you here are not surgeons, so I don't want to just talk about robotic because otherwise it's just a surgical technique. So I want to just cover very briefly some of my now this is not meant to be a complete lecture on screening, but just some of my thoughts which I want to share with you. Now this is a little bit about screening, why we screen, and how we screen. Now I just want to share with you a little bit about our group. Now we've started with 4 surgeons. We've collaborating with a Indian healthcare group called Fortis Healthcare. We built a hospital in Singapore dedicated to colon and rectal diseases called the Fortis Colorectal Hospital. It's an integrated hospital with, it's a small hospital, but we've got our own facility for rectal physiology, ultrasound, robotics, everything in that hospital. So it's all dedicated, and we've modeled it after, you know, the specialist colorectal clinics around the world. So you see, this is a model of our hospital. In fact, we just started operations this last June. So far, we have done about 500 over cases. So we are getting there. Now, I want to just cover this topic very briefly. Now, colorectal cancer, as all of you know, and here as well in Saudi, it's a major worldwide problem, increasing incidence as the population gets older. And it is the second or the first commonest cause of death in the US and UK, as well as in Singapore. Now, screening, it is a major health issue. We know that early cases can be cured, and simple methods exist for screening. FOBT has been tested and proven in at least 3 large studies, and cost effectiveness. But what is age to screen? We don't want to screen too late. So what is the right age? You look at this, I'm going to go through this very briefly because I just want to bring through an idea to all of us here. US screening age 50 to 80, European about 45 to 75. And this is what we say to people, members of the general population at average risk who are asymptomatic, without first degree relatives with colorectal cancer, no other risk factors. Most societies and most countries advocate screening at 50 years. This is the ASCRS guideline, 50 years of age. We'll just go through very briefly. The US Preventive Services Task Force, 50 years of age and above. The American Cancer Society, again 50 years of age and above. The Canadian Association of Gastroenterology, 50 years of age and above. The Australian National Health Service, 50 years of age and above. Even in Singapore, they say you screen 50 years of age and above. Now, if you look at all these various societies and associations and why they want to screen, you'll see that they say the main aim is to detect earlier diagnosis of cancer so that you can apply appropriate and timely surgery to cure the cancer. Now, this is where I'm a little bit confused, because why do we want to wait till cancer happens? Why do you want to get caught before you decide that you shouldn't get caught? So why not screen earlier? No, why wait for cancer to be present? See, there are good opportunities to pick up precancerous polyps and to prevent cancer from occurring. There are many opportunities, in fact. We know that it's more costly to pick up cancers versus polyps. But, I suspect, and I know for certain, that a lot of these guidelines are actually copied from one center, from one association to the next. And everybody talks about screening for cancer because they think that screening for polyps is not so sexy. Screening for polyps or removing polyps is not something that patients get excited about. It's nothing that we get excited about. And a lot of people say that, look, if you screen for polyps, there's not a lot of cost benefit. The American Gastroenterological Association, for example, cited one paper saying that only if you screen earlier, you only find a very small percentage, 3.5% with advanced, 3.5% with advanced neoplasm. You see, but let me just go through this. But you see, earlier screening makes a marked difference in finding a benign polyp, however, dysplastic, versus finding a cancer, however early. So if we actually screen earlier, and I want to tell you that even in Asia, where supposedly there's a lot more incidence of de novo cancer arising from flat polyps, removal of such polyps is possible through a very simple procedure called a colonoscopic polypectomy, whether you do submucosal resection or mucosal dissection. And this comes with much less morbidity and mortality. And we all know that if we do not screen for cancer, but if we screen for pre-malignant polyp, we would prevent a large majority of cancer. So why don't people do it? Because we think we should screen for cancer, but we can actually screen to remove polyps. In my practice in colorectal surgery over the last 30 years, increasingly we are doing patients at about 35 years of age and 40 years of age, routine colonoscopy and advocating that to patients. And a lot of these patients, we find polyps. Some of them have large polyps even at 35 years of age. And we know for certain that these patients, we would have prevented the polyps because we prevented the cancer because we have removed the polyps. So that's my point today about colorectal cancer. We can prevent colorectal cancer. We know that in many studies it's shown that if you do colorectal cancer surgery, when cancer is already diagnosed, it's going to be associated with a high degree of morbidity and mortality. This was a study published in year 2000 looking at colorectal cancers from 11 European cancer registry comprising about 3,000 patients. And you notice they say the wide differences across Europe depend to a large extent on differences in stage of diagnosis. So it's so important for us to actually understand that most polyps exist in the body for 10 to 15 years before they become significant enough or develop the potential to become cancerous. Now, so we have a wide window to actually screen and remove polyps and prevent cancer. If we wait till 50 years old, patient is 50 years old before we do screening, we're going to actually detect a lot more cancers, and we're going to give cancers a chance to develop before we remove them. So we won't go through this because I want to just get onto my other topic. Just to end this session to say that general population screening guidelines, and that is actually a topic of another lecture, but I think a lot of us as medical practitioners have confused our roles. If we look at a lot of papers, they talk about cost benefit, but there are three sort of different angles to look at cost benefit. One is from the angle of the government of a country. Now, the government of a country is not going to advocate colonoscopy, for example, for everybody, because they're going to say that's expensive and that's impossible. You don't have enough doctors and it's too expensive to do. They're going to say FOBT. But from the point of view of the hospital, it also then depends on whether the hospital is able to collect money for each case performed. If they are able to collect for each case performed, they may actually make a profit from doing colonoscopy. But then, most importantly, and as doctors, our responsibility is not just from the point of view of the government or the point of view of our hospital, but also our point of view of the patient. The patient comes to us as an individual. Now, this patient, whether he has symptoms or not, comes to us with a problem. So they say, I'm worried, I may have cancer, whether they're 35 or 55. Do we say no, to him? Because general population guidelines should not be the same as those used to evaluate a patient in the colorectal clinic. And remember that prevention is better than cure. Detecting a polyp and removing a polyp is as important as, if not more important than actually treating a cancer, because you can actually prevent cancer and decrease the burden on the patient, on the hospital, and on the country. So if you are government, screening would consist of the FOBT test. But if you are a general practitioner, again, FOBT is a good test, but if we are colorectal surgeon, we need to be sure we are not missing a colorectal cancer in anyone who is worried about that, irrespective of the age. Over the last, just to share in ending this lecture, over the last 2 years, I've seen 3 young ladies, 18 years old, 20 years old, and one 24 years old. The last one just delivered a baby a month ago. And all 3 of them had colorectal cancer without family history. So that's something we need to think about. We can actually do more screening to prevent cancers. I just want to say a little bit about this meeting. This is the European Asian Colorectal Technology Association. We're going to have a meeting this year, 6 to 9 of November in Singapore. And for those of you who would like to visit us, this is a good chance to come and see the country. We promise you an exciting social and scientific program. You can log on to www.ecta2013.com to register and get more information. Now, I want to just share a little bit about innovation, and I think that's probably more interesting in laparoscopic surgery, as well as to talk about some of the innovative techniques that we have come up with and we are teaching so that we get better results. Now, keyhole surgery doesn't mean you see less. In fact, we can see much more with keyhole surgery. So I want to share with you how we can actually get more with less. We have shared a view of this in the old days when I was training as a surgeon in the early 80s. My professor used to say, big surgeons make big incisions, but all that is changing. And even when we started laparoscopic surgery in the late 80s, we put a lot of ports in, and even now there are surgeons saying, look, put as many ports as you like, but I think that part of the reason for laparoscopic resection is recovery, and the speed of recovery is actually related to the number of ports. And also, another reason is cosmesis. The less ports, the better cosmesis. The less ports, the less the pain, the better recovery. More port site means more scars. Now, robotic surgery is a new innovation. I will talk a little bit about that, but I want to just tell you today about some of the innovations in laparoscopic surgery that we can use to improve recovery of patients and improve our results. At the moment, the routine laparoscopic robotic surgery uses too many ports, but that's going to improve, and I will just say a little bit about how we're improving that as well. Now, the traditional laparoscopic colorectal surgery uses a lot of ports. 5 to 6 ports is normal. Firstly, with that sort of number of ports, we need more manpower, and training is a problem. And a lot of surgeons I know, they can't operate unless they got their usual team with them. So that limits the usefulness of laparoscopic surgery. And because of that, you need more training, you need more understanding between team members, and of course that comes at an increased cost. And then there's always that specimen extraction and through a muscle splitting incision, which increases the morbidity post-op. So today I want to just share with all of us here some innovations, and this I want to share in this 4 or 5 points here, something that's radically different. Okay, I want to share something about single port laparoscopic surgery. I want to share you something about nodes and nose, use of the umbilicus as a port site, and how we can actually decrease the number of ports. Now, some of you who are non-surgeons may not have heard of this, but recently we are doing a lot of single port laparoscopy. That means patients only have a single small wound, maybe about 3 centimeters or so. Now there are various techniques. Okay, I want to just share with you. These are our commercial techniques. You know, using gel pot, using the Johnson & Johnson equipment or the Covidian, or using a glove. Now these are something that I want to share with you because these are things that we can use. And the glove, in fact, I'll say a bit more about it in a while, is our favorite technique at the moment. Now, single port, where all instruments go through one single port, and usually we use the umbilicus. Has been said that it is the future of laparoscopic surgery. The major advantage over standard laparoscopic surgery is cosmesis. In fact, a lot of times when the wound heals, you know, you can't even see the wound because it's buried within the umbilicus. The risk of potential complications like hernias, hematomas, wound infection is very much reduced. Technically, of course, it's more challenging, but it's something that we can do. And we have this is a study that was published from Indiana, or rather Indianapolis, USA, 100 patients. They did a lot of different operations through this single port. This is one of my patients. You can see that just through the umbilicus. Single port laparoscopic colectomy is associated with less post-operative pain and shorter hospital stay. And single port surgery, compared with conventional laparoscopic technique, single incision laparoscopic surgery results in similar intraoperative and post-operative outcomes. So, you know, it is not something that is so difficult. Single incision laparoscopic surgery does require more effort from the surgeon. Okay, and you see this is just a tiny scar. Sometimes when things get very difficult, what we do is we just put in another 5 mm port by the side, and that makes life all so much easier in difficult cases. But in non-difficult cases, with a single port, we can do a lot of operations. But adding one tiny 5 mm incision at the side gives you an advantage in cases where difficulty is encountered. You see, this is where it is. So this is another single port. Because this patient had a big tumor, we added a small port here, and we're able to do the operation. I want to just show you, this is a single port right hemicolectomy, just to show those of you who are non-surgeons what we do nowadays. You can see that we have these two instruments, and we are able to, with, you know, appropriate handling over one instrument to the next instrument, we're able to slowly tease or to slowly cut at the planes that we like to cut and mobilize. This is the liver, so we can mobilize around the hepatic flexure and slowly mobilize the right colon downwards. Once we have mobilized the whole right colon, you know, it is a simple measure of a decision of whether we want to take the artery and the veins intracorporally, or we can deliver the whole right colon outside the wound to then divide the vessels outside the wound, okay, depending on technical ease. Because I think that the surgeon should not be a slave to the technique. The technique should be a slave of the surgeon. So we use whatever technique and whatever innovations that we find suitable for the particular patient, and use it to the patients as well as to our own advantage. Now, I don't want to show the whole operation here. I want to talk to you a little bit about the glove technique. Now, in the glove, instead of using a commercially available single port device, what we do is that we use a port, what we call a wound protector, and we then put a glove over the wound protector so that the glove sits over that port, and then we can use the fingers to insert our equipment. Okay, and this is actually very cheap. And you see, this is a paper from Dublin. They say that the use of the glove pot reduced trocar costs by about 60%. By allowing use of, by doing away with trocar sleeves, and also we can now put as many instruments as we like, although it's just a single pot equipment. So the glove pot technique is economically very favorable, and this is something that we've been using. And even in robotic surgery, when we put on the robot arms and we need to put another arm for the laparoscopy equipment, we use a single pot over that incision, so it allows us to be more flexible in the use of our equipment. Now this is something else that I want to share with you about that we have been using. You know that the TEMS transanal endoscopic microsurgery device is quite expensive, and it comes with its own equipment. But nowadays, if for low rectal cancers or big polyps, we've been using this Covidian single port device, inserting it through the anus. We use a normal laparoscopic equipment to remove big polyps, and this is something I want to recommend to those of you who want to start this technique with normal equipment. So we call this a TAMIS, and it's a feasible alternative to TM, providing its benefit at a fraction of the cost. Of course, you can see these are other devices which have been used. Okay, this is NOTES is natural orifice transluminal endoscopic surgery. It is still very much in infancy. We have tried a few cases. So putting the camera through the umbilicus and putting another pot through the vagina, it is something that we think needs a bit more work on, and we are not doing this routinely at the moment. Okay, now what about extraction of the specimen? Okay, we can extract through the mouth or through the vagina, through the rectum or through the umbilicus, and you just go through this. Now transanal specimen extraction is something that we have not used very much. Again, we use an Alexis wound protector. We insert it through the anus, we divide the specimen intracorporally, and we can extract it through the rectum. Okay, it is alright for small tumors, but for large tumors often it's quite difficult. You see here how it's done. Okay, we won't go through that tonight. So transanal or transrectal extraction may be useful for small tumors. It is difficult to insert and extract large tumors through the rectum, and sometimes it's difficult to protect against cancer spillage when it's dragged through the anal sphincters. Transvaginal extraction we are not very much in favor of, because we find that it only works if you're actually working on the female genital tract at the same time. Otherwise, we find that there are some significant complications. When tumors are big, you got to make a big hole in the vagina, and that may cause serious. There were 2 serious complications reported in this series. One of pelvic seroma, one of rectal vagina fistula. Okay, so we are not so keen on that. Now, transoral extraction, you know that it's not really possible except for small objects. We know of the famous case from Dr. Reddy of All India Institute, where he extracted and did an appendicectomy and extracted